So for those of you who are interested in receiving CME credit for today's presentation, please take note of the activity code for today. I'm going to go over some additional instructions here in just a moment for those who have not yet registered, but if you have registered, please text attend and then today's code to the toll-free number listed there, and make sure you do that before midnight tonight. It did this last time. Give me 1 second here. Sorry about that. So as we get started here, we do have a few participants who are on Zoom, so we'll ask that you please make sure that your microphone is muted. And for everyone, if you could please be attentive and engaged in the session. I will also be submitting to everybody today in an email the evaluation form, so if you can help give some feedback on this presentation. We want to remind everybody that we are partnered with the TAFP for this presentation this evening. Our department's mission statement is listed there for you. And so getting to the CME credit, here's the code again for today. If you have not yet registered and you are looking to do so, please text your email address to the toll-free number listed here. You do have to have a Utisca CME account first. So if you're having any questions or any issues, please feel free to reach out to me. For those who are on Zoom, I will put my email address in the chat. But for those who are here, I'll be over here in the corner. So if you have any issues, please stop by. Those who are registering for CME, please make sure you do check every so often to make sure that your credits are showing up on your transcript by visiting the Utisca CME office website listed here. And also we do offer AAFP credit for those who are members of the AAFP, but if you have any questions, please contact them or contact myself as well. We are also wanting to make sure that we address these nationally established physician core competencies as part of our Grand Rounds presentations. And we also just want to mention that Dr. Beck has no financial relationships with ineligible companies to disclose. So as mentioned, she's going to be presenting to us Got Bugs, I've Got Legal Drugs, the Antibiotic Guide Part 2.
Thank you, everyone. So after 2 years of teaching virtually, we are running into technology issues, and it's okay. I can adapt with it. So I do have polling questions, and I can't download the software onto this computer. So we won't be able to see the feedback live, but that's okay because I have my phone and I can see that, and I can let you guys know what the responses are. And so this is part 2, because last year I gave part 1 of this lecture and I covered different bugs. So last year I covered Mrsa, Pseudomonas, and anaerobes. So this year I thought, let's try something different. So I feel like we always talk about Mrsa, Pseudomonas, and anaerobes, but this time I want to talk about 3 different bugs. So for poll everywhere, you can join by texting Tina Beck 899 to 22333, or on Zoom, you can enter through this website, the pollev.com, Tina Beck 899. So the 3 bugs we will be covering tonight is going to be the Streptococcus species, the E. coli, and Enterococcus infections. And then we'll list common monitoring parameters as well as adverse effects related to these. I know the world has been focused so much on viruses with the COVID virus, and now with monkeypox being a national crisis. But I know, I think bugs and drugs has always been a hard point, and unless you do it every single day, it's hard to make it stick. So again, hopefully this will be a refresher for some of you guys, and for the medical students, hopefully you're like, either go, I got sketchy in my brain, or I'm good on this part. So as I mentioned before, I have no financial disclosures to, or conflicts of interest to disclose. I also do have a disclaimer. I may present an antibiotic may be, quote, covering a pathogen, but please do realize there may be non-FDA approved indications. So even though an infection may be caused by a quote said pathogen, we may not have the FDA approval to use that antibiotic for that infection. So a common one will be daptomycin, which has MRSA coverage, but we don't use it to treat MRSA pneumonia, and that's because the drug does not work in the lungs. And so again, just because a drug has coverage, it does not mean that automatically we are using this antibiotic to treat every infection caused by said pathogen. So this slide or meme shows that pretty much it is true. When something happens, the three most common pathogens we think about is Strep Pneumo, E. coli, and Staph aureus. Again, today's topic will not cover Staph aureus as I covered that in part 1 last year. So this is your first polling question. Your honest thoughts about infectious disease. So I'm a pharmacist, but I love infectious disease. Love it. And it's okay if you are not a fan. I know a lot of pharmacy students are not a fan of infectious disease. So again, this does not show your responses, but I can look on my phone. And it should let you guys enter it. Is anyone having issues entering? It's locked. We will unlock it. And people on Zoom, again, you can text or you can use the website on the top of the slide. So it looks like majority of you guys, about 70% say it's okay. I got about 15% that says I'm not even going to try. And then I have 20% saying you love it. So we're going to start off with the Streptococcus species. And so next question. This is a word cloud, so you can free text and it should show up, and it's going to show up on my phone. So let's test your baseline knowledge. When you hear Streptococcus species, what class of antibiotics do you think of? And I do apologize again, it's not showing up on the screen, but if you are on the website, you probably can see it live going on the website. All right, so majority of you, or the biggest words on my screen right now, are Cephalosporins, Penicillins, beta-lactams. We do have some macrolides popping up as well in the word cloud. So first, to let you know, there are different types of strep species. So I know we always talk about, I think with pneumonia, we always think about Strep Pneumo. And I think that's probably one of the most common ones we encounter, especially as family medicine physicians in your clinic or in the hospital if you are a hospitalist. But we also have Strep Pyogenes. So Strep Pneumo, again, is what's going to cause pneumonia. Strep Pyogenes, which is a group A strep, causes strep throat. Viridin strep is a different class of Streptococcus, and it's different in regards to how it, on an agar plate, how it hemolyzes different things. We have Strep Agalactiae, which is your group B strep, and that's probably the most, quote, wimpiest strep there is of the strep world. And then you have Strep Angiognosis, and the ID pharmacist told me many years ago, this is the MRSA wannabe of the strep world. So he's trying to be tough. He wants to become drug resistant. He wants to look like he's, you know, a big bad guy. And we are seeing some resistance develop to strep angionosis. So when you do see strep angionosis, please do know that look at your susceptibilities, and we'll talk about what generally covers strep angionosis. But again, it is the MRSA wannabe of the strep world. And then there are many, many, many more strep species. So for most Streptococcus species, when you see first-line choice of antibiotics, you should be thinking the beta-lactams, specifically the class of penicillins or cephalosporins. And I'm sorry on Zoom land because I can't see you raise your hands, but how about in here? How many of you guys knew there were different classes of penicillins? So there are actually different stages of penicillins, even though we don't actually like call them, this is this stage penicillin, but there are different classes of penicillin and then the different generations of the cephalosporins as well. So this is a busy slide. You're gonna be like, this is first off, it's gonna be your natural penicillin. And this is gonna be, again, your Pen G. And in the oral formulation, we have Pen VK. And this is, again, the first generation, if you want to think about generation-wise, of penicillins that was discovered. And I put all the spectrum on just for completeness sake, but again, I'm trying to focus in on Streptococcus. So it is great. Let me omit somebody. It is great for Streptococcus species in general. We have great coverage for Strep Pyogenes. So it is the drug of choice for strep throat. So you can get away with prescribing Pen VK for strep throat as an outpatient. It does have great coverage. Strep pneumonia, we are seeing resistance slowly develop across the different classes of penicillins. So it may not be your best choice empirically if you are treating someone with Strep Pneumo, and which is why, again, you don't see us treating CAP with Pen VK orally, or even Pen G IV or IM in the hospital setting. It used to be able to work for Staph aureus, but now we are seeing very little Staph aureus be covered by the natural penicillins. We do have some anaerobic coverage as well as some gram negatives. And then of course, this is our drug of choice for syphilis. So if you do have syphilis, please think of the natural penicillin class for your treatment coverage. Then the penicillin class got more advanced and we moved to the penicillinase resistant penicillin. And this is because the bugs got smart. We were using the natural penicillins a lot, and the strep mostly, or the other bugs we used it for, started developing resistance, saying like, oh, we can outsmart this. And so if you see the penicillin resistant penicillin, you may also hear this called as anti-staph penicillin. And this was pretty much developed for Staph aureus specifically, and it's great for MSSA. So methicillin susceptible Staph aureus. Please know that we only have one PO option. So if you are going to prescribe this as an outpatient, there is only one, dicloxacillin. Again, it's great for MSSA, but it will cover your strep pathogen as well. The bad thing about the dicloxacillin from a PO standpoint, it's usually dosed QID. So it's not the greatest drug from an adherence standpoint or for ease of administration for patients to stick to. If you are working in the hospital setting and for medical students going through your rotations, if you do see that you have MSSA, we have the 2 IV naproxen and oxacillin available. Each hospital will have their preference on which one they prefer. Primarily, oxacillin has been seen with better safety tolerance in regards to kidney dysfunction. So we are actually seeing a lot more nephritis with naproxen compared to oxacillin. So from a safety standpoint, oxacillin was kind of preferred, but again, your facility may have naproxen on formulary to use as well. And then we have the Amino Penicillin, and I just kind of like to think of it as a pun on words, a mean old penicillin. So we have now expanded our coverage a little bit more, and this includes your non-beta lactamase gram negatives, including E. coli, which I will talk about later in the presentation. And this one, we have our amoxicillin as our PO option, and ampicillin is our IV and PO option. Again, ampicillin, though, is not generally well liked by patients because in general, it is a QID potential dosing. So again, as a pharmacist, I should be better, but I have horrible medication adherence. you do not want me as a patient. So if you ever see me in your clinic, I apologize because you probably don't want to give me a drug more than once a day because I probably will forget that BID dosing. So again, the amino penicillins, we've now added more gram-negative coverage. Again, though, it is the drug of choice for Strep pneumoniae. So for otitis media, so ear infections for our children. I have 2 kids. They are Petri dishes right now of daycare germs. And we have been on otitis media treatment for a long time. So Strep Pneumo causing the upper respiratory infection, specifically otitis media. The amino penicillins are our preferred drug class, as well as your strep throat, your Strep Pyogenes, again, is coming in play. It is also the drug of choice for your Enterococcus species, and which I'll talk about at the end of the presentation. Our Enterococcus species, when I get there, there's not a lot of choices we can give from an outpatient standpoint. But I want you to think about amino penicillins. They've now expanded coverage to your other bugs, including a lot of your gram-negatives. So we also have our last class of penicillins, the extended spectrum. Okay, and I think from the hospital, we are always hearing Teza or Zosyn, right? It's always vancomycin. That is the combo everyone thinks. And no, it does naturally mean if you see Vanc, does not mean you have to order Zosyn. I've had a pharmacy student tell me that, saying like, the Vanc is on board, we must add Zosyn. I'm like, why? They're like, because the Vanc is on board. I'm like, it does not mean you have to give it together. But I am going to specifically focus in on amoxiclav, which is your PO option of this spectrum. And the extended spectrum, amoxicillin was the amino penicillin, and we extended spectrum because you added the beta-lactamase inhibitor. So again, our bugs are getting smart, and it was able to bypass some of these drugs. And now we added a chemical entity to try to prevent that resistance mechanism a lot of these gram-positives and gram-negatives are developing. So your amoxiclav, you have the gram-positive, including your Streptococcus. So again, as you go down the different classes of penicillins, you're adding more. So you're adding more gram-negative coverage, but your Streptococcus species is still pretty much there. Although your natural penicillin, again, we're losing that coverage for Streptococcus species. This is also nice because we got the gram-negative coverage again. I know I'm not talking about specific disease states of like UTI, skin and soft tissue infections, but depending on what disease state you are treating, and what bugs you are thinking about coming up as, what pathogen is likely causing this infection, you can think of amoxiclav does have gram-negative coverage. It does have anaerobic coverage. The beta-lactamase inhibitor adds anaerobic coverage that amoxicillin generally does not have the greatest of, including your Bacteroides species. But the one bad thing about amoxiclav is that it has more GI disturbances, or your diarrhea specifically, compared to your amoxicillin. So I always tell people, patients, depending on the dose of amoxiclav that you're adding, you may need to tell your patients, you may need to go to Costco and pick up a side of toilet paper while you're picking up your prescription, because it is much more GI disturbing than amoxicillin. And it is a clavulanic acid component that makes it more GI upsetting. And that is why there usually is the clavulanic acid will be your dose limiting factor for prescribing more than the amoxicillin component. So the question becomes, we always get this question, right? Patient has a said, quote, penicillin allergy. What do we have if I can't give all those penicillins I mentioned before? So what is the cross-reactivity rate to cephalosporins if someone has an allergy to a penicillin? Is it not working? Let me unlock it. Like I said, 2 years of virtual teaching, I have gotten very good at navigating technology issues. Still seeing a little movement on the poll. Okay, so 45% of you are saying 10%. Then the next one was C at 27% saying less than 5%. 18% of you saying D less than 1%, and then 9% said 20% cross-reactivity. So if you look at the actual literature, we say 10%, but if you actually look at the literature, it actually shows we are about a 5%. And that goes from penicillin to the first generation cephalosporins, okay? And as you go down the cephalosporin generation, that cross-reactivity actually further decreases. So the question becomes again, if you have a penicillin patient, allergic patient, what do you have as an option? And we'll now go into the cephalosporins. Unless they have true anaphylaxis, so an IgE mediated hypersensitivity, cephalosporins are still an option. And we are actually finding out that most people who say they have a quote penicillin allergy do not have a penicillin allergy. They usually say they had GI issues, or they were told that, you know, as a child, they couldn't tolerate it. And mom told me I have a penicillin allergy, and now it has carried forward into my adult life. So something to think about as you see your patients and their allergy list. So your first generation cephalosporins, we have your Cefazolin, which is your IV, and cephalexin is your PO equivalents of it. And again, I gave you the entire spectrum, great for MSSA, but again, it's also great for your strep pathogens, including group B, so Strep Angiognosis, Strep Pyogenes, which is your group A strep, and then Strep Pneumo. We do have some gram-negative coverage as well. And then again, if you are in the outpatient setting and you're like, let me just do PO first generation, it is Cefazolin. Depending on your indication or infection you are treating, the dosing can be BID to QID. So again, for skin and soft tissue infection, please don't give me cephalexin, because I definitely cannot do your QID dosing. I've been on it for a skin and soft tissue infection, and my 5-day course ended up being a 9-day course because I kept missing my doses. Again, you don't want me as a patient in your clinic. And again, this is where that 5% cross-reactivity for your penicillin allergic patient, this is the class that has the highest cross-reactivity. As you go for the different ones, it drops much lower. Your second generations. So this is special because you're probably like, we don't see a lot of these second generation cephalosporins being prescribed, especially in the IV setting. We definitely don't really use it a lot. And then in PO setting, maybe cefuroxime is probably the most common one you may prescribe to your patients as an outpatient. And cephalosporin, probably not as much, although I think cephalosporin for pediatric becomes as a suspension may be used a little bit more often. The second generations, it has its specialty in its place in covering certain bugs. And that is that compared to your first generation, you're adding now the gram-negative anaerobes, specifically the Bacteroides species that when we think about anaerobes, we always think about that's the bug that you really want to target is the Bacteroides. And so the second generation does actually have that coverage. It's great for gram-positive. So again, you do have your Streptococcus species coverage. And then your cefoxitin is Q6 to Q8 hours versus cefotetan is your Q12. So think about that again from a patient overall transitions of care and making sure that they complete their treatment. Cefuroxime and cefaclor are very similar to amoxicillin in regards to its coverage. So again, if you have someone you're like, I want to do amoxicillin, and they're like, pen allergic, and you're like, I can't do a penicillin, you can go to the second generation cephalosporin, and it'll be very similar in coverage. The big thing will be, though, the Enterococcus coverage is not there. And again, we'll discuss more of that when I do Enterococcus in a little bit. The third generation cephalosporins have become the workhorse of the cephalosporin class. I think we all think in the clinical rotation setting, in the hospital setting, ceftriaxone, right? They have an infection, ceftriaxone. Whether they really need ceftriaxone, whole nother story. But cefotaxime and ceftriaxone are our IV drugs. Great strep coverage, especially for Strep Pneumo and beta hemolytic strep, which includes your Strep Pyogenes and your Strep Angiognosis. And MSSA, and for Strep Angiognosis, which I told you is the Mrsa wannabe, If you are worried about it and you are in the hospital setting, you can get away with a third generation cephalosporin. We are actually seeing ceftriaxone works beautifully for Strep Angiognosis. The gram-negative coverage is a huge advantage over your first two generations. We have way more gram-negative coverage compared to your first two generations. And in fact, I'm not going to talk about STDs, although if you guys want me to, I have a whole presentation ready for that one. Gonorrhea Ceftriaxone has moved as our drug of choice for that one. It does not cover your more typical multi-drug resistant pathogens, including MRSA, Pseudomonas, your Acinetobacter, and it does not get your anaerobes. So again, depending on what infection you're like, I need to cover some strep, I need to cover some anaerobes, and your third generation probably is not the best because of the lack of anaerobic coverage. So this is more specifically again for your third generation. It's a long half-life. You can get away with a Q24 dosing, potentially Q12 if you need it to give more frequently for more serious infections. The beautiful thing about ceftriaxone is there is no renal adjustment. So you can have someone on ESRD on dialysis, and I don't care about dosing. I'm like, give them ceftriaxone at their full dose. Don't have to worry about their kidneys. So that's a specialty, because I think we always have to think about what is this patient's renal function? Do I need to dose adjust anything? And if not, pharmacy will come after you. Dr. Falcon can attest to that. We avoided the neonates. So if you are taking care of neonates, ceftriaxone is not preferred due to the biliary sludging. So that is something different about ceftriaxone. And cefotaxime, there's less protein binding. So you do need to renally adjust this. And if you need to use a third generation in the neonates, if you are taking care of them, cefotaxime is your IV third generation of choice. Septazidine, I think there's a shortage of it right now. So even if you wanted to use Septazidine, you probably will be getting a phone call from pharmacy saying like, do you really need Septazidine? It has poor activity on the gram-positive aerobe. So again, this may not be Septazidine, may not be your drug of choice for your strep infections. So again, if you're thinking strep, Septaz, do not use. Its niche is Pseudomonas, okay? And that's where Septazidine will be really coming in for. But if you want to think about your other antibiotics for a Pseudomonas coverage, there's so many other choices without having to ask pharmacy for a drug that's on a national shortage. Your PO options via cefodoxime and cefdinir. It is your third step down from your IV if you need to. And a nice tip is if you have susceptibility reports back, if it says susceptible to cefazolin, which is your first generation, you can assume it will be susceptible to your third. So even though you don't see the S next to cefodoxime or cefdinir on a susceptibility report, if you see the S next to cefazolin, it tells you your PO options for cefdinir and cefodoxime are viable. And this is great from a transition of care from inpatient to outpatient to finish out courses of antibiotics. Not going to talk too much about cefepime because it's IV only, so you'll see it in the inpatient setting only. Great strep coverage, okay? But I think we think more cefepime for the gram-negative coverage that the other cephalosporins potentially are lacking as you go from first to second generations. So fourth generation, we only have one. It does get your Pseudomonas. It has good gram-positive as well. So if you think about it, ceftriaxone plus ceftazidine had a baby, it's cefepime, okay? So your two third generations created this fourth generation. Again, though, your multi-drug resistant pathogen, MRSA, is not there. There is no anaerobic coverage, and that's the biggest difference. Just throwing a clinical pro out there between cefepime versus piptazo. In the hospital setting, everyone's like, what's the difference between piptazo and cefepime? Piptazo, again, has the anaerobic coverage because of the beta-lactamase inhibitor. Cefepime doesn't. So if you are worried about anaerobes for an infection and you want cefepime, you need to add metronidazole to get your anaerobes. As I mentioned, a great thing to know, PO or IV, except for ceftriaxone, you do need to look at your patient's renal function. Especially cefepime can cause encephalopathy, especially if you overdose or you start accumulating too much of cefepime. And all the beta lactams, actually, if you accumulate too much of it because you did not renally adjust, the potential for seizures is there. If you look at the literature for how much you need to overdose someone on penicillin to induce a seizure, it's actually quite a lot. So don't be like, oh my goodness, I forgot to renally adjust penicillin and now I'm going to give a seizure. You may, but again, if you look at the literature, it's actually like 10 times, like you need to overdose them 10 times to actually induce a seizure in somebody. For the it's well tolerated for the ADRs. All antibiotics, if you hear the commercials, it's always going to be like, may cause nausea, vomiting, headache, diarrhea. That's the standard, I feel like, across all of them. So you will have the GI disturbances. You may have people complain about headaches and dizziness, but overall, they're pretty well tolerated drugs. And again, the specialty of, or the niche of cephalosporin is if you have someone who is said pen allergic and you need to cover strep, you do have cephalosporins as an alternative. So those are your two big workhorses. I do want to go very quickly into some of the alternatives. Please do not empirically write for carbapenems or glycopeptides or fluoroquinolones for streptococcus infections. We have other, again, Streptococcus in general, it's pretty susceptible to the beta lactams. That should be your first drug. When you see strep, you're like, I need to give a beta lactam of some kind. For the fluoroquinolones, I'm not going to talk about it in this section. I'm going to talk about it in the E. coli section, just because we see more of it for E. coli than for strep coverage. Carbapenems as well. I'm going to talk about it in the E. coli section. And then your glycopeptides, I'm not going to spend a lot of time on it, but if you want to think about what it is, that's your vancomycin. That's the class of antibiotics that vanc is a glycopeptide. Again, you have to be in the IV setting, inpatient setting. Please do not prescribe PO vancomycin, okay, for anything other than C. diff. Okay, remember, I don't know if how much chemical or chemistry you have or medicinal chemistry. Vancomycin is a giant molecule. It cannot cross the gut lumen, which is why it's great for C. diff because it stays in the GI tract. Any other systemic infection, your PO vanc is stuck in your GI tract. It's not going to treat it. So please, please, please do not write for PO vanc for non-C. diff infections. I think I'm just going to touch on vancomycin just a little bit because I think when you go through your internship or clinical rotation, I feel like vanc is the drug that everyone's like, get pharmacy on board. We don't want to touch it or we don't want to do it. Please note your frequency is based off your renal function. That is how you determine what the frequency of vancomycin is. Your dose is based off of weight and its total body weight. So even if you have someone who is obese, you will do the total body weight. And do know that each institution will have their protocol on capping it at a certain amount. So you will still calculate what their dose is using their total body weight. If you have someone based on the math, you're like 3 grams of vanc. Okay, pharmacy is going to be like, what are you doing when you try to enter 3 grams of vanc into the system? Vanc, though, if you want to think about the things about vanc, gram positives, all gram positives. Okay, so Mrsa, that's where it's niches, not VRE though, but your Streptococcus will fall under vancomycin. It is, again, not preferred. Again, it has to be inpatient setting. And then we are always worried about nephrotoxicity with vancomycin. So we don't really like to use it for non-MRSA infections. Monitoring, it's going to be your vanc trough. Just wanted to let you know that the 2020 guidelines actually don't recommend troughs anymore. They actually prefer AUC to MIC, but no hospital that I am aware has implemented this protocol yet, just because it has not been cost effective, because you need to download a software, which costs many, many, many $1,000s to the healthcare system to get this calculator on board. And it requires 2 levels. Okay, we have a hard time getting nurses to draw vanc troughs, 1 vanc trough on time. Trying to time 2 levels may be difficult. And again, it is not cost effective yet, even though the guidelines do prefer that we do the AUC to MIC for monitoring. Red man syndrome, which is no longer preferred, is now the IDSA is trying to push from the terminology away from red man syndrome to vancomycin infusion reaction. Okay, so that is a new PC term, if you hear that, for it. But it is a histamine related reaction. Please do not tell me that they have a vancomycin allergy and we cannot do vancomycin ever again. Just slow down the rate and just give some, you can give some PO antihistamine prior to infusion. As I mentioned, a huge thing is nephrotoxicity, especially with the supratherapeutic troughs. And then if you have someone on long-term vancomycin, you have thrombocytopenia and neutropenia as a potential side effect. So if suddenly patients on weeks and weeks and weeks of vancomycin and you see CBC and everything starts to drop, you may want to think about vancomycin causing that drop. All right, so we got some new kids on the block here. So antibiotics have not been in the forefront of drug development. And I like to do new kids on the block because they were new in the 90s, okay, and they came back. And so you will actually see some of these new kids on the block drugs are actually old drugs coming back / new. So they really are the new kids on the block. You have another glycopeptide, you have dalbavancin. It does cover MRSA and that's where its niche is, but because it covers skin and soft tissue infections, it does cover Streptococcus species, especially that causes skin and soft tissue infection. The beautiful thing about dalbavancin, it is one and done. So one time infusion and you can say skin and soft tissue infection, treat it. We don't need to continue days worth of antibiotics. And there is limited evidence right now potentially as an osteomyelitis source, but it's not in the guidelines yet. So again, please know that this covers streptomycin, but if you're trying to use strep for a non-skin and soft tissue infection, it is not FDA approved to use that for non-skin and soft tissue infections. Because it is a glycopeptide like vancomycin, you do need to renally adjust it. So watch your renal function. But again, one and done, you don't have to worry about the nephrotoxicity building up as time goes. It's got a long half-life, so it actually goes, and the pharmacokinetics goes, it's in your system. So it's like you've gotten many, many days of antibiotics.
So then you alluded to use osteo. Why isn't this really?
Because osteo, we're looking at a 2 and done instead of 6 weeks of treatment.
How expensive? This is pretty good.
It is very expensive. It's a few $1,000s per dose. So again, I have no financial disclosure, so I am not pushing dalbavancin on anybody. It is just something that is new and it's very interesting. And so we are seeing limited evidence for osteomyelitis. Instead of 6 weeks of treatment, we can do 2 and done potentially. Yes. Depending on which hospital system, for university health, ID controls this. You cannot, it will not pop up on the MAR. So if you want dalbavancin for at least at university health system, the ID pharmacist is in charge of entering it. She's the only person that can enter it. So it's not somewhere where you're going to be like, let me enter it and let's see. That's a quick way to get ID phone call, pharmacy phone call. Again, I didn't talk too much about the fluoroquinolones, but I'm saving that for the E. coli. But we do have a new fluoroquinolone on the market. Again, though, I put it here because it does cover Streptococcus. But again, the FDA-approved indication is acute bacterial skin and soft tissue infections. So again, that's why I put it here. The beautiful thing about this one, it is PO and IV, just like all our other fluoroquinolones. And it also has coverage for community-acquired pneumonia. Again, since it's just came out on the market, very costly. So depending on your patient population you are dealing with, most of them probably will not be able to afford this. But this is the neat thing about this drug specifically, you have Pseudomonas and MRSA coverage together in one drug. So this does cover MRSA and it does cover Pseudomonas. Again, this is not the focus of my talk. I brought it in because it does cover the Streptococcus. It is a, let me think about the dosing. I've double checked with you on that one. I think it's twice a day, just like all your other fluoroquinolones, but I will double check. So what, oh, I'll save the questions later. So next we're gonna go into E. coli. Still good on time. This is a word cloud, so again, you can put whatever antibiotics you think will cover E. coli. I will let you know the big one that's showing up big is macrobid, fluoroquinolones, cephalosporin is coming up, but it's tiny right now. Tetracycline's coming up. All right, so the big ones that I see is Bactrim, macrobid, and then the cephalosporins are coming in tiny. And we have other random antibiotics coming in. So when you think about E. coli, this is again a general, it's not the law. Think below the diaphragm. So think strep above the diaphragm, E. coli below the diaphragm. So most commonly you will encounter E. coli for your UTIs, and that is our #1 pathogen for UTIs, and as well as abdominal infections. So I'm going to start off with Nitro Furantoin. So that was a huge one on this word cloud. So it does cover E. coli. It is beautiful for E. coli. The only issue though is it concentrates in the urine. So it's great for cystitis for UTI, but again, nothing else. So if you are worried about an intra-abdominal infection with E. coli, nitrofurantoin, not going to do anything for you. If you are worried about pylos or anything related to the kidneys, it does not penetrate the renal parenchyma. So again, it's not great for pylos. So if you suspect pylo on anybody, yes, E. coli is probably the most likely pathogen. Nitrofurantoin is not going to get to your site of infection, and it will not work. For men, this used to be always like nitrofurantoin is a woman's drug because, again, cystitis. We have evidence we can use it in men, assuming that their UTI that you're using it for is not caused by prostate issues. Okay, so if you're worried about prostatitis, nitrofurantoin does not penetrate the prostate gland. So therefore, you will not be doing anything. You may be treating E. coli in the bladder, but you have not attacked the primary source of your infection, which is the prostate, and therefore your patient probably will come back to you with recurrent UTIs. There is, quote, low collateral damage, meaning, yes, it covers E. coli. It covers other pathogens beautifully, but again, its primary source of action is in the urinary tract system, specifically the bladder. So again, you're not going to kill off E. coli in the GI tract and worry about, creating a super bug or a super flora. Do you know there is a common dosing error with nitrofurantoin? We have 2 salt formulations. We have macrobid, which is your nitrofurantoin monohydrate and macro crystals. There's 2 salt formulations in that. And then you have macrodantin, which is your nitrofurantoin macro crystal, which is the crystals. The dosing frequency is different. So if you are wanting BID dosing, the way to remember is macrobid, it ends in BID. That's how you know you want to do the BID dosing, okay? There was a study that showed in a small retrospective chart review thing that the most common error was prescribers choosing macrodantin and then prescribing it BID. Okay, the macrocrystals are short, don't have as long of a half-life, or it does not last as long in the body, which is why it's a QID dosing. So if you did macrodantin BID, you're giving patients part of the time without adequate concentrations of the antibiotic in their system, in the urinary tract system. So again, macrobid, way to remember that, it ends in BID. That's how you know that's the correct dosing. Overall, it's pretty well tolerated, but it has been known to cause pulmonary toxicity. And this is why it's on the Beers criteria for not used to use in the elderly patients. It says it can happen in any point of time in treatment therapy, so acute versus chronic. But what we're seeing is that it's most likely seen when you're using it for chronic prophylaxis for UTI. So patients are on it for a very, very long term, and that we're seeing the pulmonary toxicity. We can also see hepatotoxicity, so LFTs can start rising. Again, not very common for acute indications of nitrofurantoin, but you may see it if you have someone on it for a long time. So if you're like, I want to do UTI prophylaxis, let me prescribe nitrofurantoin, something to think about. And then peripheral neuropathy, it's not something that we think about common, but it can happen. The good news with the peripheral neuropathy is once you stop the Nitro Furantoin, it will reverse. So it's not going to be like you caused it and now they're stuck with peripheral neuropathy forever. So something to think about, especially as we have a huge diabetic population here in San Antonio with a lot of neuropathy as a consequence of their diabetes. You may not want to exacerbate it more with nitrofurantoin. The contraindications, again, I'm not doing a UTI talk specifically, but you may be prescribing a lot of antibiotics to pregnant women for asymptomatic bacteria. Nitrofurantoin, though, its contraindication is 38 to 42 weeks of gestation, so right before delivery. So you cannot prescribe that if you are seeing asymptomatic bacteria in your pregnant patients. And that's because we saw a hemolytic anemia in our newborns when the mother took it during this late gestational period. Creatinine clearance less than 30. So again, we do actually have a hard cutoff of creatinine clearance less than 30. It will not concentrate in the urine. So again, you're giving them placebo. They're taking it, but it's not going to do an adequate job. If you look at the package insert per manufacturer, their cutoff is 60, creatinine clearance of 60. And if you look at some drug resources, it will still say creatinine clearance less than 60, it's a no-go. We have pharmacokinetic studies that actually looked at this saying, what happens if we did drop the creatinine clearance a little bit lower and still gave it to our patients? Will we see the efficacy? And we did. So we say 40 to 60, we're still seeing the efficacy of nitrofurantoin concentrating in the bladder for UTIs. Once we get to 30, though, we're like, it doesn't work. So again, something to think about for your elderly patients or anyone with renal dysfunction. And then your G6pd deficiency is another contraindication. I'm not going to repeat all the beta-lactam slides because we already covered that for strep, but in general, I think third generations definitely get your E. coli. So whether you do IV or PO, and that's why in the hospital setting, when someone comes in for UTI, we're like, give them ceftriaxone IV. It does cover it very well. Other generations will cover it as well. The first generation is plus or minus. So I would not start an oral first generation empirically for E. coli because unless you have susceptibility report saying, yes, it is susceptible. But your fourth generation, which is IV only, gets it. Your second generations will add the gram-negative coverage and it will cover it as well. And then your specifically your extended spectrum penicillin with the beta-lactamase. So again, from an outpatient perspective, a MOX class, your augmentin will cover E. coli. Fluoroquinolones. So I focus mostly on the E. coli. Just you know that the fluoroquinolones do cover some strep. Strep Pneumo, though, ciprofloxacin is not preferred. It's, quote, not a respiratory fluoroquinolone. And it does not mean cipro does not penetrate the lungs. It penetrates the lungs beautifully. It doesn't cover your most likely pathogen for lung infections, which is your Strep Pneumo. But again, it does cover a lot of your gram-negatives. However, the US has a problem with resistance with fluoroquinolones. Everyone got prescribed a fluoroquinolone for any little infection. It was either azithromycin or a fluoroquinolone, right? Everyone was like, I have a cough. Here's a fluoroquinolone. Here's a azithromycin. So here in the US, we are seeing a huge rise of fluoroquinolone resistance. And here in San Antonio, we're above 20% resistant rate. So again, I probably would not be choosing it empirically unless you are in an area that you know does not have the high resistance rate to fluoroquinolones. If you are doing fluoroquinolones, you have your, again, renal adjustments that need to be done. Again, great antibiotic though if you're hard to reach places. So again, hardware, the prostate, if you do have someone with E. coli or prostatitis, one of the two antibiotics of choice will be a fluoroquinolone or trimsulfa. And however, again, besides the resistance rate, the FDA is really pushing us away from prescribing fluoroquinolones. And that's because pretty much for a while, almost every month or so, the FDA would be like, new warning with fluoroquinolones, new warning with fluoroquinolones. And so it became not the greatest. Besides clindamycin, it is number 2 likely to cause C. diff in patients. So if you do prescribe it, you may be putting patients at risk for C. diff. This glycemia, it can cause hypo or hyperglycemia. So especially with our diabetic patients where you're like, what is going on with their sugars? If you put them on a fluoroquinolone, it may be the reason why you're seeing such fluctuations. We are seeing more hypoglycemia than hyper, but we do have evidence it can push blood glucose elevation. The QTC prolongation is another huge thing. Please make sure you look at your patient's medication list and you're not stacking QTC prolonging drugs on top of one another. Pharmacy is also great if you need to call them to help you do that. Photosensitivity. We've had some cloudy days for the last few days, but though this summer was pretty hot and pretty brutal, you don't want probably to send your patients out here in San Antonio on a fluoroquinolone without adequate shade because they will get sunburn pretty easily. Hepatotoxicity. And then I think some of the new things that came out recently is the peripheral neuropathy. We are seeing that, again, another drug that's causing peripheral neuropathy in our patients. CNS effects, altered mental status. So we are seeing patients come in with altered mental status. And the question always is like, especially in the elderly, it's a new infection. They probably have an underlying infection that's causing the altered mental status. It may be that, but if they were being prescribed a fluoroquinolone as an outpatient, it may be that drug actually causing the altered mental status. Myasthenia gravis, you always have to think about certain drugs not to use in myasthenia gravis. This one has the black box warning. So if you have a patient with myasthenia gravis, do not use fluoroquinolones in general. And one of the new things that came out was related to aortic ruptures or tears. So we were actually seeing patients or increased risk of aortic ruptures or tears. And so they say any cardiac history, and they include hypertension as part of that cardiac history, they should not be on a fluoroquinolone. I'm like, so then nobody would be on a fluoroquinolone. Just think about everyone with hypertension. Just something to consider, but that is what the FDA is saying is even hypertension puts you at a risk for an aortic tear if you are on a fluoroquinolone. That's what I said. The FDA is keep putting out warnings, whether we see them or not, but they're really trying to push us away from the fluoroquinolone. So the next one is, which one is reserved for the drug resistant E. coli, specifically ESBL, and this is a select all. I know students hate select all questions. All right, so the poll stopped moving. So I have 70% saying carbapenems. Okay, it's changing. People are changing their answers. 75% are not saying carbapenems. 17% are saying the 4th generation cephalosporin. And if I do my math right, that leaves about 8% or so saying phosphomycin. So the correct answer actually, we'll go over it in a little bit. I'll leave you on the suspense. So phosphomycin is another antibiotic that's probably not commonly used, or you may not see it as often. It does great for E. coli. However, the only FDA-approved indication right now is uncomplicated UTI. You have a lot of off-label use being used for it. And then Canada has the IV formulation that the US does not. So I didn't talk about the IV, but there is IV phosphomycin if you cross the border up north. The nice thing about phosphomycin, it's another one and done drug for E. coli. If you're using it for UTIs, it's a nice little packet powder. You mix it in water and you drink it and we're done. There is some new literature about, again, like extended duration of doing every 48 to 72 hours for a week for some of your more complicated infections. But that's a nice niche about phosphomycin. Again, E. coli coverage, one and done. However, the downside is the cost. It's still brand name only. It's monorail, and it's without insurance. It's $40 for this one packet. So some of our patients may not be able to afford phosphomycin. We are seeing it as a potential oral option for some of our more drug-resistant pathogens, specifically related to the urinary tract infections. So again, this may be an option right now. We don't have a lot of oral options for ESBLs. So if you have fluoroquinolone resistant ESBL, trimsulfa resistant ESBL, this may be an option in the future. So we may want to try to preserve it as long as possible to be used for multi-drug resistant pathogens. Carbapenems, again, not first line, very broad spectrum. Not only E. coli, you got some gram positive, you got some gram negative, you got all kinds of coverage with the carbapenems. There's a meme or a video about how to get to get pharmacy to find you, and you enter meropenem, we will come find you. Okay. We're gonna be like, nope, you're not getting meropenem. It is reserved for the multi-drug resistant pathogen, but as you can see here, the limitation of the carbapenems, we have no PO options right now. So if you do require a carbapenem with ESBL, everything is IV only for us. There was a study that got published in April for an oral carbapenem. Looked beautiful. You're like, all right, we may have an oral option. FDA has rejected the approval, and they are saying that when they ran the data, it did not match what the study showed. So FDA has nixed it. I'm not going to go too much into it because, again, we have IV. Do you know that we do have a lot of options? We have meropenem, IMI, and doripenem. Gram positive, if you want it, imipenem has more gram positive coverage. So if you want strep coverage, potentially, imipenem. If you want more gram negative, meropenem is more likely to have your coverage. And then ertapenem is the exception. That's how I remember it. It's E for the exception. No pseudomonal coverage compared to the other carbapenems, and no enterococcus coverage compared to the other. So E for the exception. It wants to be a carbapenem, and is for the most part is, except for Pseudomonas and Enterococcus. And its niche is for home health, especially since, again, IV, if you need to use it, it's a once-a-day drug versus the other drugs are dosed. Meropenem is Q8 hours with normal renal function. So again, it may be more difficult to transition someone out from home health if you needed a carbapenem. Renal function is huge. Everything needs to be renally adjusted. There is no exception to that. Pretty well tolerated. Huge thing, seizures. Okay, so if you have someone with a history of epilepsy, probably not the best drug of choice empirically. And imipenem has been the most associated with the seizures. So if you do have to use someone for a CNS infection, meropenem is your drug of choice to try to prevent that seizure. But technically all carbapenems has that seizure warning. So something to think about with anyone who's on any epileptic drugs. New kid on the block. Here we go. Again, we mentioned the fluoroquinolones. It does have Mrsa, it does have pseudomonal coverage, but again, it's only indicated for your skin and soft tissue infections. So probably not the best for E. coli infections, but technically it's a fluoroquinolone. It will cover E. coli. And then here, like I said, it's like the old drug, making it new. We have meropenem. We already know meropenem. We have added something to it to try to make it new. So we have the meropenem vaborbactam. It's used for complicated UTIs, as well as then we have imipenem, celastin, and relebactam. Again, imipenem, celastin, we already had that drug on the market for years. We throw on some relebactam and we're like, it's new. Market it as a brand name and let's charge a lot of money for it. It does have, its main indication is for HAP-VAP. It can be used for complicated UTI. So again, below the diaphragm infection, if you have no alternatives. But again, it's new on the market. It's going to be very costly for our patients. All right, almost done, I promise. Enterococcus. So you have a patient coming into your clinic for UTI symptoms, and your rapid identification tells you that she has E. faecalis growing in the urine. You're still waiting on susceptibilities. Which of the following do you prescribe? This is, again, outpatient setting. We do know that susceptibilities can take a day or two to come back. And let me make sure it is not locked. Going back to the previous poll, I've heard a question about what to use for your drug-resistant E. coli. So the correct answers were carbapenems and phosphomycin. Okay, the poll has stopped moving right now. 56% of you are saying doxycycline. We have a tie of 18% both for ceftonir and amoxicillin. And then 9% of you are say admit to hospital for IV ceftriaxone. So the correct answer is amoxicillin. The one thing I want you to know with Enterococcus, the whole in spectrum is a gram-positive, and we always think about, again, all the beta-lactams. Cephalosporins do not cover Enterococcus. That is the whole in its spectrum. So it will cover a lot of things just like your penicillins do, but not Enterococcus. So no cephalosporin, PO or IV. So even if you want to admit to the hospital, ceftriaxone would not be the correct antibiotic to give. So again, no that's the whole in the cephalosporin spectrum. Great gram-positive coverage. Depending on the generation, you get some gram-negative coverage, but there is no Enterococcus coverage. We have Enterococcus faecalis and faecium. Faecalis is the most common one we encounter. Faecium is more drug resistant. So if you look at what we are using generally for Enterococcus treatment, if you look at, if this comes back as faecium, you're actually going to see the susceptibilities of those antibiotics just drop. In general, if it's, you got to check your susceptibilities. If it's ampicillin susceptible, again, your amino penicillin is going to come into play. So you can get away with your ampicillin or amoxicillin as your preferred agent. If it is AMP resistant, you're going to have to probably send them to the hospital because they're going to probably need vancomycin. Because again, we don't have a lot of Enterococcus, besides the beta-lactams, we really don't have a lot of drug choices for Enterococcus infections. For the most part, our Enterococcus here in San Antonio has been pretty benign. They've been pretty wimpy. They're ampicillin susceptible, although we are seeing a slight uptick in the ampicillin resistant Enterococcus. If you are now seeing vancomycin resistant Enterococcus, we have now bypassed it, and the drug of choice is linezolid. So daptomycin does not cover this. The nice thing about linezolid, PO and IV. So you could potentially get away with a PO option to be treated as an outpatient. The bioavailability is 100, it's the same. So whether it's IV to PO dosing, if you're like, they're on IV linezolid, discharge them. Just convert it to 1-to-1 for your PO dosing equivalents. It gets gram-positive. So if you think about all gram-positives, and I didn't talk about linezolid for Streptococcus, it does cover strep, but we, again, do not prefer linezolid to be like strep. If you write for linezolid, pharmacy, again, will be calling you. We have a lot of GI upset for the PO option. And then they're, nice thing about linezolid with its side effects, it's time dependent. You can almost predict exactly when you're going to start seeing the side effects happen. And so the first one you're going to see is going to be your hematologic effects, 2 to 3 weeks, which is why we don't use linezolid for more than 2 weeks in general, because once you go beyond this point, you are now cascade, you're going to trigger all these side effects to happen. The nice thing is if you do see thrombocytopenia, you stop linezolid, it will reverse back. Optic neuritis, it is reversible. If you're going to have someone on long-term linezolid treatment, they do need to get an eye exam for baseline vision test, because if they go into optic neuritis, you can stop it. It is reversible, but it's not going to be like, oh, we stop linezolid, tomorrow your vision will be back to normal. It will take some time. The neuropathy, it is time delayed and it may not be reversible. So again, we see a lot of peripheral neuropathy as the side effects of your other antibiotics. This one, you stop those and it'll reverse back. This one, you may not be reversing it back. And then lactic acidosis for more than 4 weeks. We actually have a drug-food interaction. The charcuterie board is huge right now. Like everyone's all about the charcuterie board. If you're on linezolid, you can't be hip. Okay, you can't be cool. And that's because if you have tyramine-rich foods, which is in a lot of your deli meats or your fermented foods, you can actually cause hypertensive crisis. And then the drug-drug interaction, serotonin syndrome, it's very structurally similar to an MAOI. And so therefore, if you have a lot of serotonergic drugs or drugs that act on the serotonin receptors, you can actually trigger serotonin syndrome. It is rare, 0.4%, but as I was told when I was at BAMC as a resident, they're like, I am not risking 0.4% chance of giving this general serotonin syndrome. I'm like, fair enough. So we had to change their antibiotics. You can't. So if they're on a high dose SSRI, if you stop at cold turkey, you're going to withdraw. They're going to make the patient withdraw. You can potentially try to taper, but again, you could drop the dose a little bit. Hopefully your patient is not on linazolid for more than 2 weeks where you're like, we have to taper our entire SSRIs completely off and then retitrate it back up. Most likely, again, unless you have VRE specifically, I would just change antibiotics. I'd be like, we don't need linazolid unless you specifically have VRE or you're like, I have no choice. So just in general, when you see Streptococcus, think your beta-lactams, specifically your penicillins and your cephalosporins. Again, your penicillin allergic patient, go to the cephalosporin unless you have a true IgE mediated response. E. coli will be covered by the cephalosporins for the most part. And most of the agents we have are specifically related to UTIs. That's where we're seeing a lot of the E. coli drugs come in. Enterococcus should be susceptible to the amino penicillins. And again, here in San Antonio, we are seeing a good percentage of that happening. But the cephalosporins, again, that's the whole. So please, again, if you see Enterococcus, to be like, here is your cephalosporin. Doxy was not correct because doxy is not used for UTIs. We don't have the FDA approval for UTIs. It does actually, or if you look at our resistance pattern to doxycycline to Enterococcus, it's actually dropping. So we're actually seeing more increased resistance to the tetracyclines for Enterococcus. So it may not be a great empiric drug anyway. And please, again, do not forget to renally adjust most of your antibiotics. A lot of side effects patients will have is because they are accumulating too much of the antibiotic and now they're seeing GI upsets, which again, will then make patients stop taking it. And then that causes superbugs because we have resistance and the antibiotic steward in me is cringing, although I am probably that patient too. So what questions do you guys have for me? Hopefully, again, this was a good refresher of certain common bugs that you will see for. I am primarily in the acute care settings. I deal a lot more with IV drugs and PO, but I know in practice, you probably will be prescribing a lot more PO antibiotics. What questions? Yes. So UHS specifically has an antibiogram. It is on Epic. So we used to have the paper antibiogram. They decided to save money from the printing costs. And now if you go into Epic and look at resources, you can pull up UHS's antibiogram. The VA, if you practice at the VA, your antibiogram actually looks very different. We're right across the street from each other, but it's amazing the differences you see in our susceptibility rates. And that's because, again, different practitioners has different choices of antibiotics used, as well as our formulary may be a little bit different. So you'll see a difference in our antibiogram. One nice thing about UHS, if you are UT, one side gives you the inpatient antibiograms or resistance pattern there, but the other side gives you, the second page gives you outpatient resistance patterns as well. I do not know if we distribute ours too, because again, it's very institutional specific. So again, we're UH and VA, we're right across the street, but our antibiograms are very different in regards to susceptibility percentages. Sure. People are answering the questions. Any other questions? So the pharmacokinetics, I think just because tetracyclines are usually 4 gram positives, and we don't really see a lot of gram positives except for Enterococcus in there. And again, we have other amino penicillins are probably our preferred agent. I don't think there's a lot of studies looking at doxycycline for UTIs to get the FDA approval to be like, this is indicated for UTIs. Ooh, good question. Can I use phosphomycin in pregnancy? I'll have to double check on that one. I usually don't deal with pregnant one, but I will double check on that one. Thank you.
Okay, thank you, Dr. Beck, for the presentation. So, let's go to the next item on our agenda. And goes, item 5 and 6, we have no report from officers today and no new business to discuss. For item 7, announcements. So the next meeting will be on Tuesday, September the 27th. I will not be, available for the meeting, but the host will be our president-elect, Dr. Raquel Avery, so she will be here for that meeting. Does anyone have any questions or any comments before we entertain a motion to adjourn the meeting?
So I just wanted to make a point on August 26, 1972, our residency was first accredited, so this is our 50th year.
Anyone else with any comments or any, information? Okay, a motion to adjourn the meeting?
So
Okay. So have a great evening.